Today, we will be focusing on recognising substance-related risk in primary care and how we can work together to support patients safely. This is something many of you will already see in practice and often in brief consultations with patients. So presenting today is myself, Chloe Baxter Vickers. I'm the Primary Care and Development Lead for Change Grow Live in Birmingham. And we also have Kerry Clifford, our Quality and Governance Manager, and Leanne Connolly, our Team Leader. Okay, so just to frame why we're here, substance-related risk is something primary care encounters, as I've mentioned, and people are presenting often coming in with their other health needs. Also, primary care plays a key role in spotting risks early, and even the small interactions can make a difference. So today is really about making this simpler, recognizing risk earlier, feeling more confident, and knowing when and how to reach out to us. This is a national data from the Office for National Statistics. They released in October each year. So we learn about drug-related deaths and data. Drug-related deaths are at the highest on record, and we are seeing increasing risks linked to synthetic opioids, particularly nitazenes. We're going to talk about that a little bit later. Deaths are significantly higher in men, and cocaine-related deaths have now increased for over a decade. Importantly, this reflects what we're seeing locally here in Birmingham. This isn't just national data, so it has relevance for your practice. These aren't just statistics, these are people who are in our communities.
Yeah, so hi everyone. Just wanted to kind of bring it back to a kind of local perspective really across Birmingham. So this is the most recent Birmingham data that we have. Most deaths, as Chloe has said, are in men, which is around 74%, but there's still a significant proportion of deaths within the female population. What's particularly important is where the risk sits. We're seeing the highest number of deaths in people aged between 40 to 45, with a wider spread across the ages 35 to 59. So for general practice, this isn't a niche group. This is a population that many of you will be seeing on a regular basis. And this shows the substances most commonly involved in any local drug-related deaths. Heroin and cocaine remain the most prominent, followed by alcohol, but both illicit and legal substances are contributing factors. What's particularly important for primary care is that the number of deaths involving medications, including Pregab, methadone and diazepam. So this isn't just about illicit drug use. This is also about prescribed or partially prescribed medication, which continues to present a significant risk. And often these drugs are used in combination. We know that also clients may be presenting who have been buying pregabalin or diazepam illicitly, and then attending primary care services asking for GPs to prescribe this. So we know that this will hit your practices. Then this slide, it's quite a fussy slide, but it kind of details more look at the combinations of substance uses involved in deaths locally. So the colours kind of represent quarters in terms of years. What's important is that we're rarely seeing that a death is from just one substance on its own. Most deaths involve multiple drugs and often including prescribed medication. Generally, we see quite a lot of opioid deaths that involve then pregabalin, diazepam, and various other prescribed medications. And this significantly increases the risk of overdose amongst that population. In primary care, we're often not seeing the full picture, so patients may not turn up and disclose all of the different medications. So we do regular checks with our GPs to make sure that we're on top of medications that are prescribed. But as I said previously, a lot of this can also come from the illicit market. And it's not just, sadly, in one area of Birmingham. As you can tell from this map, it's widespread across the city in terms of deaths. And again, we're seeing that mix of substances involved. So for us, it's really important that we can support our local primary care services and that you're aware of the services that we offer and how we can support you going forward. So that's what we're seeing locally in terms of substances and patterns and where the risks sit. It's basically for us to try and support you in how to recognise the risk when somebody may present at your services. So many of the people who are out there and who are using substances never reach our services, which were classed as specialist services. And often it means that you may be the people who will pick up the early warning signs when somebody presents at your practices. And we know that there's a stigma attached to substance misuse and people who use substances. And often that can be a barrier for people engaging in treatment. But we know because of other health concerns, they may present at your practices, and how we can work together and you can work to try and improve that engagement and get them referred into services where they need that specialist support. And often just having those conversations can really break down some of that stigma and some of those barriers that our service users actually face on a daily basis. So just to build a kind of picture on who we're talking about, our service is predominantly for service users who are aged 25 plus. However, we do work in partnership with Aquarius for those under 25, particularly those who have clinical need. Polysubstance use is really common. So a lot of our service users will present with alcohol, heroin use, crack cocaine, and prescribed medications. And they will also then, like we say, be prescribed other medications, which then increases the risk of overdose. There's often significant complex health needs as well. So what we've seen particularly emerging since COVID is mental health needs have increased alongside physical health problems such as COPD. So we've had a lot of deaths related to long-term physical health conditions, so poorly managed diabetes, COPD, and other long-term heart conditions as well. We also are aware, as you will be, that trauma and social factors impact on these individuals. You know, a lot of them will have issues around housing, poverty, family issues, and isolation.
Okay, so thanks, Kerry. I'm now going to run through a few substances that you may see in primary care in terms of patients presenting. I'm starting with this one, cocaethylene. This is formed in the liver when alcohol and cocaine are being used together. And it's significantly more cardiotoxic than just using the cocaine alone. So what this means in practice is patients may present to you with palpitations, chest pain, anxiety, insomnia, and for example, someone might come in with those things, so insomnia and anxiety, and then through gentle questioning, you could uncover there's the alcohol use, the cocaine use. So if where the presentation doesn't quite fit, particularly with cardiac or anxiety symptoms, and you're thinking along the lines of cocaethylene, to consider those risks and make the referral. The next substance that I want to highlight is ketamine, which will be seen more so in primary care now, particularly in younger adults. It can cause significant bladder, urinary, abdominal problems. In practice, key clues could be urinary symptoms despite a normal or clear MSU, unexplained abdominal pain, or changes in mood or cognition. So if the symptoms don't quite fit clinically, it's worth gently asking about ketamine use. And if ketamine bladder is suspected, early urology referral, looking at pain management for the patient, alongside linking in with the appropriate services for under 25s, Aquarius, and 25 plus with us. I think sadly we are starting to already now see clients. We had a lady who was just over 25 who passed away, and her main drug of use was with ketamine. So this is something really to have on the radar in primary care, to talk more about with young people. So the final substance I want to highlight is nitazines. We've mentioned this in a couple of slides. Nitazines, they're a group of very potent synthetic opioids. They can be significantly, like 100 times stronger than heroin, with a really high risk, even if someone has used just a very small amount. What's particularly important to understand is that people are now taking this unknowingly, because it's not only showing up in heroin, but it's also in cocaine, fake tablets that people are purchasing, and even in other substances such as illicit vapes and cannabis products. So in primary care, this could become something that you become aware of through someone coming in with a sudden collapse, overdose, even if they're denying having used any opioid use. So again, it's where that presentation doesn't quite fit, exploring, understanding, and given the risks with substances like this, being aware of having naloxone in your clinical setting, in your resuscitation trolley, to reverse the effects of overdose should this present itself to you in your practice setting. And then finally, alcohol is something you're going to be seeing every day in primary care, and it's just putting this on the radar, as the Audit C tool is there for that quick screening, a few questions, and then if needed, go into the full audit or the SADQ to understand severity and withdrawal risks. So in practice, you might see withdrawal symptoms, physical health issues like liver disease, mental health concerns, medication interactions to be mindful of, and nutritional deficiencies. And what we'd say is just even asking one or two questions from the audit can really open up that conversation. So the key point here is utilising screening tools when you can, identifying those risks, that further assessment showing severity and guiding urgency really. So across all of these, whether it's alcohol or other substances, the key is recognising it as early as possible, knowing what to do next, and referring on as early as possible. So looking at why people may struggle to access support is an important point to make, because there's so many reasons why people struggle to access support. And as Kerry's already mentioned, that stigma is a really big one. We hear that regularly from our clients, and the shame that they feel, and just worrying about being judged or the consequence of disclosing information and what's going to happen next. Their past experience matters, whether they've been through trauma or have mental health, or they've already had experiences with negative healthcare experiences. This can then make it even more of another barrier for them to access the support they need. And then you've got practical barriers on top of that, like homelessness, chaotic lifestyles, just being able to navigate a service. So often these barriers are actually about safety, not the person's motivation. And this can influence how, when someone actually shares information in a consultation. So really just understanding that and what you can do in that consultation is important. So everything we've talked about, from hidden risks to barriers to access, can present in really brief consultations with you. But even within that, we recognise there is an opportunity to make a difference.
So we know that, your time is limited when you see somebody, and we know how busy everything is in primary care services. So we're not expecting people to be able to fix everything. For us, it's more about trying to break down those barriers for those service users. It's about being curious, and as Chloe has said, if things don't quite fit, is there possibly another reason, and how can we try and get that individual to open up and start feeling like they're being listened to, and that we're able to get a clearer picture on maybe if there is some substance misuse, what's going on for them, and also the risks that that might present for them. So it's for us, it's really about, and we do it ourselves here, it's about, you know, being really curious whilst being really supportive towards the individual, looking out for any kind of possible risks that may be disclosed, talking about simple steps in terms of trying to reduce the harm caused by any of these substances, looking at what they are currently prescribed and what those interactions may, might cause in terms of if they are using other illicit substances. Often, and we know this through our own service users, is they'll come in with a physical health concern or a mental health concern, and they may be self-medicating. And it's about looking beyond that physical health issue or that mental health issue and seeing whether there are other implicating factors, such as with cannabis use often used to self-medicate, cocaine, heroin, all the same. And for us, it's about those small steps with our individuals. It's about achievable small goals for them to set themselves, so they're not going away feeling completely overwhelmed or feeling like they haven't been heard. And we know that it's, you've got a short period of time where you see somebody, but it is just remembering that there might be something else behind that, and how can we support those individuals. And I suppose for us, it's about assessing that risk when you are seeing somebody, thinking about, what substances they're using and what risk that might present to that individual, but not only them, the wider family, whether there's any safeguarding concerns, particularly whether it's, adult safeguarding children. And I know you're on top of that in practice, and with time as well, it can be a bit of a challenge. I suppose the other thing for us is being really clear in terms of what is it that the individual actually wants to achieve, what matters to them, and what is it do they feel like they can achieve with. And it might be that they've just opened up, so actually to get them to come back and see about next steps. And then also to involve, and we found this really successful in our treatment services, is involving the family members, or if they've got a social network, and making sure that they've got that support around them, because those are the people who will support them on a day-to-day basis while they're going through some of their challenges. What we say is that if they're already engaged with CGL, then explore the wider health needs, catch up on the physical health needs. And some of you will be aware that if they are prescribed by us, we will regularly send you out updates in terms of what we're doing for them, where their prescribing's at, what their treatment plan is. It's also really important to link in with other services was needed, and in particular, social prescribing can be really helpful with our service users. For us, it's about, and you'll know this yourself in practices, it's about making every contact count so that we don't miss out on those opportunities to engage individuals.
Yeah, so we've looked at what you can do in consultation. So now we're just going to briefly touch on working together across services and the support that we can give patients together and more effectively. So good partnership working always comes with clear communication, safe information sharing, shared goals and plans, defined roles so everyone's aware of who's doing what and why, joined up responses and regular reviews. The most important thing is that we're always doing this with a trauma-informed approach across the services, and that, again, like Chloe said earlier, reduces stigma. So wraparound care, I won't go over the slide in depth, but I will go when I was an RC recovery coordinator, and I had taken over the care of one of our clients who had zero beliefs or anything in any sort of professionals. We ended up at his home address because his physical health was so poor. He closed the door on us, he swore at us and everything else. It was just a bit of persistency at the beginning with him and trying to reassure him that we was there to support him, and it's a different sort of angle we had to take this time with this particular client. after assessing his needs, it became clear of exactly how much support this client needed in relation to GPs, nurses, hospital appointments, opticians, you name it. There was so many things that he wasn't being looked after with. So it did take a lot of work trying to get GPs on board, nurses on board, X, Y, and Z, but we did get there in the end, and ultimately it gave him a better way of living. Unfortunately, the client has passed away now, but the GPs involved do believe that prolonged his life for the better. So it's just really important that we're all working together and not stigmatising, being open and honest with them and getting them to open up with you as well. Any referrals that if they've mentioned anything and you think you can do a referral to whatever services, then please do so. And I find with a lot of our service users that come in, they've either got mental health or physical health, and their drug increases to support that. But just trying to get working all together so they've got a better care plan overall. So the wraparound care is about seeing the whole person, not just the substance use. It means understanding wider needs and tailoring support to the individual with multiple services working together. This can include substance treatment, physical and mental health, and social support like housing. The aim is to coordinate the care so people don't have to navigate services alone, and this is where partnership working really makes the difference.
So I suppose for us, it's around what we offer and what we support, and we look at recognising the risk and what you can do in a consultation. So I just wanted to talk through really the CDL offer so that you're aware of what we do. So obviously we're a commission service for drug and alcohol for adults over 25 in Birmingham. We're a treatment and recovery support service across the community and clinical sessions. So we have main hubs across the city, as well as we work in community venues within shared care. So we have a multidisciplinary team, which includes recovery coordinators, as Leanne was previously. We have consultant psychiatrists, doctors, prescribers, nurses. We've now got a consultant psychologist, and we have service user representatives and also volunteers. Alongside our main hubs, we also have specialist teams across the city. So we've got a Rough Sleepers homeless team, which is based in the city centre, that do outreach across all of Birmingham. We've got a criminal justice team, women's and families team, and hospital teams who work within the acute settings to support service users who are admitted and link up them back into services with us. We offer advice and information about drugs and alcohol. So if you are ever in a session and you're kind of, I'm not too sure, you're more than welcome to contact us and ask for some further advice and support on how we can engage people. Our packages are trauma-informed care, so all of our staff are trained in trauma-informed care and motivational interviewing. We offer home visits and street outreach, particularly home visits to people who've got complex physical health needs or mobility issues. We do wound care, bloodborne virus testing, and we link up with the UHB to do the Hep C treatment. We offer residential and community detox options. We do group sessions on various subjects around building recovery capital. We have needle exchange, naloxone, and safer storage advice as well.
So we also, Kerry mentioned shared care, and that's where we have shared care where we support 39 GP practices. We've got a couple on the call that I noticed the surgeries they're at are ones that are part of our shared care scheme. Practices receive funding, they have accredited training and ongoing clinical support. A key part is having a recovery coordinator, so one of our workers actually based out within the practice. This helps to reduce stigma and it improves access. We work closely with the GP teams to provide holistic care, including harm reduction, and we support their wider health needs. So patients can still access the full CGL offer, including the groups and detox rehab, our partnership services. There's no referral needed. They just get booked in with your worker and seen. And the aim there is to improve that access and reduce stigma whilst we're supporting primary care. So if there is anyone on the call who watches this, who would like to hear more about it, do get in contact with me. Okay, so if it's helpful for you to know, we do send out lots of updates and training opportunities. We have our own trainer, Helen Dale, who runs free training sessions on Eventbrite. I will email out afterwards her link so that you're welcome to access any of the free training.
Yeah, so there are some kind of clear situations really where we kind of, you guys will recognize the risk and how then you can take action moving forward. So for us, if, you know, I suppose for you guys, it's when do you refer into our services? So if there is reported drug or alcohol use, and that can be low level to daily dependent use, misuse of prescribed medications. So we've talked about the gabapentinoids previously. If you're seeing increase in tolerance or instability or missed appointments, or there's been a history of overdose or self-harm. Our referral form is online and we'll talk through that, and we have simplified it to make it easier for people to refer in. But also, just like I said previously, you can contact us for any additional advice. If you are having MDTs, we're more than happy to be involved in those MDTs, and we can send along a team leader or a recovery coordinator to support you in actually whether that's the appropriate thing to do going forward. So for practices that are not in the shared case scheme, referrals can be made using the Arden CGL referral form. Like I said, it is pretty straightforward. What we found historically is, and we all fall into this trap, that somebody will come in and we will say, oh, here's the service, this is how you refer yourself. But we know historically that signposting isn't the most successful way of getting people into treatment. So if you can do the online referral, then we will quickly pick it up and triage that individual and make contact. Yeah, and you don't need a full history to refer in. I suppose for us, it's really like, we'd like to understand what challenges you're facing within practices and what help you feel would support you going forward. And also looking at how we can improve joint working and how we can improve attendance, because the other side for us is that often our service users are presenting to us and we know they've got physical health and we know they've got mental health, but then they're not presenting our primary care services or mental health services. So it's a two-way thing, really. So I suppose it is for us to try and understand what we can do to support you guys more.
So if there's anything at this point that you have any questions or anything you want to mention about that within your practice that we could have a conversation about, yeah, happy to unmute.
From my point of view, as long as we've got easy access to referral, so the form looks straightforward, which is what we need, because we don't want to be filling in reams of information. And it's hard to get out of patients exactly what's going on. You know, we have 10 minutes, so we don't have the luxury of time. But as long as it's easy to refer, that's probably the best thing for us.
Yeah, no, I absolutely get that. You have got limited time, and our triage team will then explore things further once they make contact with that individual. So yeah, if we can get as much, I mean, for us, the most important thing is what drugs we think they're using and a contact number. Those are the most important things, really, and everything else we can gather going forward.
Because we're not specifically trained in this area. So it's quite difficult when patients come in, even with like mental health as well, unless you've got specific training in those areas. You're limited, really.
Yeah, no, and it can be challenging, can't it? Because often
Yeah.
people present in crisis as well, don't they? So,
Yeah.
yeah, absolutely. And like I said, like Chloe said, you know, our trainer is more than happy, and she does online as well, to
Yeah.
kind of just for people, if they want to increase their knowledge, please get in touch.
Yeah. Can I just quickly ask you, you've never mentioned anything about, is it amyl nitrate? You know, the gas they're inhaling.
Yeah.
Do you have a big problem with that?
Do you know what, in younger services, so Aquarius are seeing it more than we are. We see it every so often,
Okay.
but sadly, by the time they come to us, they're more entrenched in the, you know, kind of class A substances.
All right.
Yeah, they may be using them recreationally, but definitely I know young people services have seen a lot, particularly out at festivals and areas like that. So they do quite a lot of outreach out there.
Okay. Thank you.
No worries.
Thank you. So I guess just to leave you with 3 things today, you don't have to fix everything in one appointment. That's not the expectation. Often it's just being curious, non-judgmental, starting that conversation with somebody so that they feel that they can return, and they will get the support that they need, with referrals. So spotting things early, whether that's substance use prescribing concerns. If something just doesn't feel right, do get in touch with us. You know, we are part of your team here. You don't have to manage this alone. You can refer, involve us, and ask for advice. So any small steps can just make that difference for someone. And thank you. That's our presentation for today. And if there is any other questions, please do ask.
No, I think that's everything from me. Thank you.
Thank you so much. I'm just going to
Thank
stop the
you.
recording there.
Oh, sorry,
Okay.
can I just